Welcome back to Rad on Smart Review Gastrointestinal Series. This is Episode 1, I Oncology Foundations, Workup, Intent, Planning Safety, and Cross Cutting Toxicity.
Glad to be here for this one.
Yeah, and when we think about the most dangerous error you can make in GI oncology, there's this massive misconception.
Oh, absolutely.
We tend to think the ultimate failure is choosing the wrong dose, but actually the biggest trap is answering that dose question before you've proven the diagnosis, the stage, the actual treatment intent, and, the exact problem that radiation is even supposed to solve.
Right. Jumping the gun is the real danger.
Exactly. So today we will map out the ultimate safety framework for GI targets.
It's going to be a crucial session for anyone prepping right now.
For sure. Let's ground this right away with our running case for this session. Imagine you have a 62-year-old patient sitting in front of you.
Okay. Got the picture.
They've got a newly biopsied distal gastrointestinal adenocarcinoma, progressive dysphagia, and a 9-kilogram weight loss.
9 kilograms. That's significant.
It really is. And the staging CT shows a locally advanced in primary, but there's no obvious distant metastasis. You look at the referral, and it urgently asks you to, quote, simulate for definitive radiation next week.
Wow. Yeah, we see those all the time.
Right. The patient is anxious. They want to know if treatment starts on Monday.
Yeah.
So drop into candidate mode for me. Give me the 60-second board answer here. How do you handle that?
Well, first, I would stabilize any urgent symptoms and confirm the pathology, the exact primary site, disease extent, and their performance and nutritional status.
Before anything else.
Exactly. I need to know whether the treatment intent is curative, consolidative, postoperative, or palliative. So I'd review the diagnostic endoscopy and a high-quality staging imaging.
Would you order more scans right away?
I'd obtain additional site-appropriate staging only when it can actually change management. And of course, discuss the case with surgery, medical oncology, radiology, pathology, GI, and nutrition.
Right, the whole multidisciplinary team.
Right. Before simulation, I would define what radiation is actually expected to accomplish. The planned systemic and surgical sequence, the target that must be treated, and the organs most likely to limit our dose.
What about motion management?
Good point. I determine whether respiratory or gastrointestinal motion requires a dedicated strategy. Then, I would use reproducible positioning, appropriate contrast and motion assessment, daily image guidance, and a toxicity prevention plan tailored to the site.
That is the perfect textbook canned response you want to deliver in a high-pressure testing environment.
It hits all the marks.
It really does. It answers 5 crucial linked questions, right? What is it? Where is it? What is the intent? Why radiation? And how will we deliver it safely? Let's take that first question. What is it? We have a pathology report that says adenocarcinoma. But treating based on a broad label like that, or something like poorly differentiated carcinoma, it feels like someone telling me a robbery suspect is a human wearing a shirt.
That's a great way to put it.
Right. It gives me literally nothing actionable for planning a multi-week radiation course.
You are flying completely blind without those high-resolution details. In the gastrointestinal tract, you can have adenocarcinoma, squamous cell carcinoma, neuroendocrine neoplasms.
Gastrointestinal stromal tumors.
Yes, GI cysts, lymphoma, and metastatic disease all occurring in the exact same overlapping anatomic spaces.
And they act totally differently.
Entirely differently. They follow different biological pathways, which means they demand different treatment sequences. You really have to ask what the immunohistochemistry shows.
Right, you need the molecular details.
Exactly. You have to look for mismatch repair testing, viral associations, or specific molecular classifications. Like a mismatch repair deficient tumor might respond beautifully to immunotherapy, completely altering systemic or local therapy.
Wow,
planning.
yeah. So you cannot let a vague diagnostic label harden into a definitive treatment plan before the multidisciplinary team actually confirms that the tissue answers the clinical
Never.
question. But, knowing the enemy's biology is only half the battle. Knowing what it is doesn't help if your map is off by a few centimeters. Let's talk about spatial anatomy. We need to know exactly where this thing is.
In GI oncology, centimeters dictate the entire therapeutic strategy.
They really do.
They change the staging system, the operative approach, the nodal basin at risk, the systemic regimen, and ultimately your radiation target. Take a tumor involving the gastroesophageal junction, for instance.
Right, the GE junction.
You must assign it from its epicenter, not just from whichever organ it happens to be touching. The lymphatic drainage of the true esophagus is vastly different from the stomach.
What about lower down, like in the pelvis?
Same thing. A rectosigmoid lesion needs a reproducible anatomic description based on rigid endoscopy measurements from the anal verge, not just a casual shorthand name jotted down in a chart. And an anal margin lesion is treated entirely differently from an anal canal cancer.
So we really have to document the primary site, the subsite, the longitudinal extent, its relationship to fixed landmarks.
Adjacent organ invasion, the nodal distribution.
Right, and the location of every suspected metastasis. And that brings up staging. A lot of practitioners just write current AJCC stage in their notes. That seems incredibly dangerous for a long-term follow-up.
It is. You must version label the staging system.
Version label meaning?
Meaning, in our current landscape, several GI sites are still using the AJCC 8th edition, while selected other disease sites have already moved into version 9 protocols.
Oh, so just saying current stage is essentially meaningless 5 years from now.
Exactly. Saying current stage is not durable enough for a board answer, and it certainly isn't durable enough for a longitudinal medical record. State the exact edition or version, and then explain the management consequence of that stage.
Because a T3 tumor in one version might imply surgery first, while in another, it mandates neoadjuvant chemoradiation.
Right. Stage communicates anatomy and prognosis. It's a common language, but it never replaces multidisciplinary judgment.
Okay, so we've locked in the tumor's identity and its precise geographic coordinates. We move to assessing its extent, and just as importantly, assessing the host.
Yes, the patient themselves.
But wait, looking at this 62-year-old guy, if we want to be as safe as humanly possible, why wouldn't my first move be to just order the works? Throw him in the PET CT, get the MRI, do the endoscopic ultrasound. Why isn't more data always better?
The urge to order everything is a massive clinical trap.
Really?
Yes. More data does not equal better care if it introduces noise, false positives, or delays. Imaging modalities are not interchangeable decorations for a chart. They are recommendation-changing tools.
Recommendation-changing tools, I like that.
Yeah, the baseline study is usually high-quality, contrast-enhanced cross-sectional imaging tailored to the primary. Every additional test, whether it's a PET CT, a pelvic MRI, a pancreas protocol CT, or a staging laparoscopy, it must answer a specific clinical question.
So don't just do a laparoscopy to be thorough.
Right. If a staging laparoscopy will not change management, do not subject them to the procedural risk. You only use a test when the result can alter the stage, the resectability, the intent, the target design, or the systemic selection.
So if the referral says stage the patient, that's an invitation to critically evaluate what's missing, not a green light for a scanning spree.
Exactly.
While we are mapping the disease, we also have to evaluate the patient's capacity to actually survive the treatment. Let's look at that 9-kilogram weight loss and the progressive dysphagia from our case.
That is the most critical data point in the entire consult.
More than the scan.
In many ways, yes. You must record performance status, weight trajectory, oral intake, pain, bleeding, renal and hepatic reserve, prior surgeries, and implanted devices. Concurrent systemic therapy dramatically amplifies marrow, mucosal, and cardiac risk.
So for our patient, that 9-kilogram weight loss means nutrition is not some optional side consultation you order after fraction 5 when they complain of a sore throat.
No, nutrition is oncologic selection.
Oncologic selection. I love that phrasing. It means nutrition literally dictates whether they can finish the therapy we prescribe.
Absolutely.
Because if their mucosal toxicity gets so bad they stop swallowing, they become dehydrated, their kidneys take a hit, the medical oncologist stops the chemotherapy, and our entire multimodality plan falls apart.
Precisely. Early dietitian involvement, correction of dehydration, and a deliberate multidisciplinary feeding access discussion with the surgeon is crucial.
And the type of feeding tube matters too, right?
Oh, definitely. The safest access route depends on the primary, the planned operation, and the procedural risk. A patient headed for an esophagectomy might need a jejunostomy tube, not a gastrostomy tube, because the surgeon needs that stomach to build the new conduit. You have to avoid a one-size-fits-all feeding tube rule.
That makes total sense. Okay, armed with all this data, the biology, the map, the patient's physiological reserve, we reach the most critical crossroads. We must explicitly declare our mission, intent before technique.
Intent is everything.
Looking back at our referral, it asked for urgent, definitive radiation. That sounds super official, but it's actually incredibly vague, isn't it?
It is. Definitive radiation is a buzzword, not a plan. The vocabulary of intent is strict. Think of definitive radiation as taking on the role of the surgeon's scalpel. You aren't just cleaning up margins, you are the primary weapon to eradicate the disease.
So your dose and margins have to reflect the fact that no one is coming in behind you to cut this out.
Exactly. Curative treatment is the broader umbrella, aiming to eradicate all known disease through an integrated sequence. Then you have neoadjuvant therapy, which happens before an intended operation to downstage the tumor or sterilize nodes.
And adjuvant is the mop-up operation, right?
Right. Adjuvant treats residual microscopic risk after surgery. Consolidative or ablative therapy is highly selective, focusing on treating isolated spots of disease depending on systemic control. And palliative radiation prioritizes symptom relief, explicitly balancing the treatment burden against the patient's prognosis.
And the physics of the treatment completely morphs based on which of those words you pick.
Completely.
If you're doing definitive therapy, you are taking this to a high, potentially toxic dose because you are going for a cure. But if you're doing neoadjuvant, you might stop at a lower dose to ensure the tissues can still heal when the surgeon operates a month later.
Right. If no one in the room can finish the sentence, radiation is being used because, then the case needs to go back to tumor board. Are we sterilizing a gross primary, reducing a margin risk, controlling bleeding? You have to name the problem.
Name the problem, and when you propose the solution to that problem, we need to use the language of evidence correctly.
Yes, you must separate a standard from a reasonable alternative and from a conditional recommendation.
How do you define those for the boards?
Well, a standard is supported by mature evidence and fits the patient in front of you. A reasonable alternative might be chosen due to anatomy, comorbidity, or patient preference. And a conditional recommendation depends on low certainty evidence.
So the words we use really matter.
They do. If you are citing evidence on rounds or oral boards, preserve the verbs. Should is a mandate based on strong data. May implies an option.
And a single-arm series is not a randomized comparison.
Exactly. Do not promote an emerging approach to a standard just because it relies on a fancy new technology available at your center.
Good advice. Let's transition from the theory to the physical reality. We have our intent. We need a safe simulation. I look at a simulation scan like a live musical performance. A beautiful, pristine day one scan is a total failure if it's a one-hit wonder.
That's a great analogy.
It has to be a repeatable performance every single day for 5 weeks.
Right. Consistency beats complexity every time. Most GI patients are treated supine with individualized immobilization. When it comes to fasting, gastric filling, or bowel instructions, a strict, complex preparation that the patient cannot reliably repeat is vastly inferior to a simpler preparation that produces stable anatomy.
Because if you ask an elderly, anxious patient to drink exactly 16 ounces of water 45 minutes before treatment and hold their bladder, and they fail to do it consistently,
your internal anatomy is wildly different every day.
And we haven't even talked about the fact that the upper abdomen and thorax are constantly moving.
Oh, sure.
The diaphragm is a massive piston pushing the liver, pancreas, upper stomach, and distal esophagus up and down.
Respiratory motion is the ultimate variable here. And here's a critical concept for you listening. A 4-dimensional CT scan shows you the motion envelope, but it does not reduce motion.
Right, it just takes a picture of it.
It only measures it. You must actively choose a management strategy. That could be reproducible breath hold, where the patient stops the motion entirely. It could be respiratory gating, where the machine only turns on during a specific phase of the breathing cycle.
Or abdominal compression, physically restricting the diaphragm's excursion.
Exactly. Or it could be an internal target volume approach, where you simply treat the entire path of the moving tumor. You choose the method based on the observed motion, patient capability, and organ at-risk geometry.
And crucially, you must verify the patient can reproduce it before you rely on it to escalate dose.
Very true.
This directly ties into our target design. You have your gross tumor volume, the GTV, which is the visible disease. Then the clinical target volume, the CTV, adds the microscopic risk.
The CTV is like weeding a garden.
Right, you don't just pull the visible weed. You have to treat the root system you can't see. Then the internal target volume, the ITV, accounts for the breathing motion. Finally, the planning target volume, the PTV, accounts for daily setup uncertainty.
What's the biggest trap there?
Oh, the temptation to cheat. Do not silently enlarge your PTV because you're secretly worried about microscopic spread. Putting a bigger fence around the garden doesn't kill the roots. It just irradiates more healthy tissue.
Exactly. Every margin expansion serves a specific, separate physical or biological purpose. Blurring those lines degrades the plan. Furthermore, do not blindly copy a nodal atlas without reconciling it with the actual primary location, the planned operation, and the episode-specific evidence. You're treating a unique patient's lymphatic drainage, not tracing a textbook diagram.
Okay, so the plan is built. Now we enter the execution phase. Closing the loop. We have to deliver this safely over weeks, protecting the surrounding anatomy as things inevitably shift. This is the domain of image-guided radiation therapy, or IGRT.
And daily image guidance requires an action rule, not just the act of acquiring an image.
Meaning you have to know what to do with the picture.
Exactly. The treatment team has to know exactly what will be matched, which shifts are allowed, and what anatomy triggers a repositioning or a resimulation. Bony anatomy is often an entirely inadequate surrogate for a mobile soft tissue target.
Right, matching to the spine does not tell you if the stomach is full or if the tumor has shrunk.
You have to constantly ask,
Yeah.
has gas, variable filling, weight loss, or tumor response invalidated the original plan?
If the patient loses that 9 kilograms during treatment, their outer contour shrinks. The distance from the skin to the tumor changes, which alters the dosimetry.
So you have to adapt.
Right, adaptive replanning isn't just a prestige feature for an academic clinic, it's a necessity. If the target coverage or the organ at risk dose no longer represents your approved plan, you adapt.
And speaking of organs at risk, let's break down toxicity profiling by tissue behavior. In the GI tract, we primarily navigate 2 types of tissue behavior. First, hollow viscera, like the esophagus, stomach, small bowel, and rectum.
What's the main issue there?
The pathophysiology here is acute inflammation leading to mucosal breakdown, which causes late complications like ulceration, stricture, fistula, or frank perforation. For hollow viscera, small, high-dose regions matter tremendously, especially if you're using hypofractionation or if there's gross tumor invasion compromising the wall integrity.
And the second type?
Second, we have parallel organs like the liver, kidneys, and lungs. These are sensitive to the total volume of functional tissue receiving dose. A parallel organ is like a battery. You can destroy a small portion of it, and as long as enough functional reserve remains, the organ continues to work.
So for parallel organs, the mean dose and the preserved low-dose volume often dictate safety more than one isolated hotspot. And, the prevention plan begins way before fraction 1. Optimizing hydration, controlling nausea, coordinating chemotherapy. But translating this massive physics-heavy process to the terrified patient sitting in front of us is a vital skill. You want to use ordinary, reassuring language. A useful version is something like, before we choose a schedule, we need to be absolutely sure what type of cancer this is, where it's spread, and if our goal is cure or symptom relief. We're going to coordinate with your surgeons and medical oncologists. During planning, we use special scans to measure exactly how your body moves so we protect your healthy tissue. Your nutrition and symptom control are just as critical as the radiation itself, and we will adapt our daily plan if your anatomy changes.
That really demystifies the physics.
It builds trust through operational clarity.
Absolutely. Now let us synthesize this entire framework into testable recall. Here are the 3 oral board traps. Trap 1, giving a dose before stating the diagnosis, stage, resectability, intent, and indication.
A classic.
Trap 2, treating PET-CT, MRI, endoscopic ultrasound, and staging laparoscopy as a universal checklist instead of selective recommendation-changing tools. And Trap 3, calling a technically advanced plan safe without proving reproducible anatomy, motion management, explicit image guidance rules, and a toxicity monitoring plan.
Okay, I'll counter those with the 5 board pearls. Pearl 1. Every GI recommendation answers 5 questions. What is it? Where is it? What is the intent? Why radiation? And how will it be delivered safely?
Good.
Pearl 2. Version label the staging system and preserve the strength of the evidence statement. Pearl 3. Nutrition and symptom stabilization dictate whether curative multimodality therapy is actually deliverable.
Crucial point.
Pearl 4. A motion assessment scan only measures motion. A motion management technique must control or incorporate it. And Pearl 5. Daily image guidance requires an action rule, not merely an acquired image.
Perfect. Let us move to board blitz. I will throw a scenario at you. Give me the reflex action. Case 1. A patient with a newly diagnosed upper GI cancer is referred for urgent definitive radiation. The exact primary site is unclear, pathology is broadly labeled, staging is incomplete, and the patient has severe weight loss. What is the first management step?
Reflex action. Stabilize urgent symptoms and complete the recommendation-changing diagnostic, staging, nutritional, and multidisciplinary assessment. I absolutely do not choose definitive targets or dose until the tumor board has established the primary, histology, extent, resectability, fitness, and treatment intent.
That's spot on.
All right, my turn to throw in at you. Case 2. A pancreas target moves substantially on a 4-dimensional CT. Does that 4-dimensional scan alone constitute motion management?
No, it characterizes motion. The reflex action is that the team must choose and verify an active strategy such as reproducible breath hold, gating, compression tracking, or an internal target volume approach, and then use image guidance and margins consistent with that chosen physical strategy. Okay, case 3. A patient loses substantial weight during a long GI chemoradiation course. Daily imaging shows the stomach and bowel have shifted into the high-dose region, but the target still appears completely inside the planning target volume. Is treatment automatically safe to continue unchanged?
No. Planning target volume coverage does not prove that the organ at-risk dose remains acceptable. The reflex action is to review the anatomy and the dose consequence, correct reversible setup problems, and replan when the approved normal tissue assumptions are no longer valid.
That makes perfect sense.
And, if we connect this entire session to the bigger picture, the final takeaway is this. You must treat radiation oncology not merely as a mechanism for delivering dose, but as a dynamic problem-solving discipline. The patient's anatomy, their nutrition, and the specific clinical goals drive every single technical decision you make. Internalizing this framework will make every subsequent disease-specific case significantly easier to reason through. That is the perfect foundational mindset. Next time we review these topics, we'll apply this exact framework to esophageal and gastroesophageal junction cancer, focusing on anatomy, pathology, workup, AJCC, 8th edition staging resectability, and the surgical decisions that shape multimodality treatment.
Get show notes and complete practice oral boards at radongsmartlearn.com and subscribe for our next episode.
Thanks for tuning in.